Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. It's a real pleasure to be here in Islamabad for this first IAS Educational Fund meeting in Pakistan. Thank you for joining us this morning. I've been tasked with giving the updates from the Brisbane meeting, which happened about 10 months ago. The IAS 2023 meeting, we're very much almost ready to go for the Munich larger AIDS 2024 meeting. So forgive me if some of the content of my presentation this morning is a little bit out of date. We were planning to come here a lot sooner than in May, but as you know, things get in the way, including your elections, your national elections. So this meeting is a little bit delayed. You might also see that I have something like 80 slides, but I'm not going to go through all 80 slides. It was just a compilation of many of the interesting presentations that we had in Brisbane. And I'm just going to give you some highlights in about 15 to 20 minutes, I've been told. So I'm going to race through some of them. The first is, of course, a plenary by one of our governing council members, Andrew Grulich from Sydney, just kind of setting the scene of what is happening with the global AIDS pandemic. We're more than 40 years into the pandemic. We have so many tools, both in prevention and treatment. We have set ourselves a goal to achieve by 2030, but are we there yet? The goal for eradication is, of course, it is impossible because of the nature of the disease, the asymptomatic phase of the infection, plus the absence of a vaccine and a cure. But we certainly have the tools, like I said, to reach the sort of the elimination, if you like, and a reduction of HIV incidence as much as possible. And those tools that we have are, of course, treatment, very effective treatment, PrEP, very effective prevention, biomedical prevention, but along with other tools like harm reduction, condoms, etc. The issue is because of the lifelong adherence, it's going to be difficult to achieve complete elimination. So you all are very familiar, I'm sure, with the 95, 95, 95 targets, which sad to say, and I'll show you in the next slide, our region, Asia Pacific, MENA region, are the two regions, along with Central Asia and Eastern Europe, are the ones that are not kind of really achieving those 95, 95, 95 targets that we have set ourselves for. And the other presentation, the other detail that Andrew Grulich shared with us is, of course, that the full potential of PrEP has not been realized. Again, our region is one of the regions, as you can see there, is very, very far away from reaching the targets, the estimated coverage that we need for PrEP to make it effective. So like I said, by region, Asia and the Pacific is behind compared to Eastern and Southern Africa, and even to some extent Western and Central Africa in terms of the number of new infections. When I say behind, it's when the decline in the number of new infections not as steep as what the world has been seeing in Eastern and Southern Africa. Our decrease was only by 14%, as opposed to close to 50% or above in Sub-Saharan Africa. And so colleagues, we still have a lot of work to do in our region, and really to make full use of all the tools that we have. This is an example that it can be done. Okay, the example is from Sydney, where they have a lot of resources. They have had decades of exemplary leadership and investment, financial investment in the HIV response. Nevertheless, it just shows that it can be done, and Sydney or New South Wales, Australia in general, is well on its way to possibly being the first country to eliminate HIV. Certainly, I was in Melbourne a couple of weeks ago for the Regional World Health Summit, and they are on track to do that. There are other good examples of countries, low middle-income countries, that have reached the 95 targets, albeit with international investment from either the Global Fund or PEPFAR, and those are countries like Botswana, Zambia, Cambodia, and Thailand have really done extremely well in expanding treatment and ensuring good viral load or undetectable viral load levels at a population level. Now, very quickly moving on to what's new in antiretroviral therapies. Again, colleague Claudia Cortez did a great presentation. Quite a fair bit of the conference was discussing the newest of the antiretrovirals, and that's the long-acting cabotegravir and rilpivirine and lenacapavir, which had recently received either FDA or the European approval. The issue with this long-acting, and there are several more in the pipeline in various phases of development phase. There was also much discussion around how can this be implemented in lower middle income countries, because there are challenges in relation to delivery of these extended release preparations, because they require intramuscular or subcutaneous delivery, and also with rilpivirine, it requires a cold chain. So do we switch to long-acting when and if it ever comes to low-income countries? Because at the moment it's still rather unaffordable. Although long-acting cabotegravir, there is a compulsory licensing agreement with Medicines Patent Pool to provide it at a lower cost to several countries, but certainly it is not widely accessible at the moment. And when it does come to our shores, like I said, there are some implementation considerations, including the cold chain, correct dosaging, and also a different kind of training for staff and community members needed to deliver this. However, colleagues in South Africa did a modeling of the effects of using intramuscular cabotegravir and rilpivirine to see if this is something that South Africa would or should take on. And the modeling suggested that the combination of this therapy will offer potential benefits because of improved adherence and so forth. But at the present moment, to be cost effective, it probably should be targeted to individuals who might otherwise have suboptimal adherence to the current antiretroviral therapy, which is really already one pill a day. So I think that there is still a lot of discussions to be had in terms of where long-acting antiretroviral therapy will find its place. Is it going to be suitable for first line for those who are antiretroviral naive, or should we just limit it to those struggling with adherence? Moving on to quite a bit of discussion around side effects and long-term complications of long-term treatment of antiretroviral therapy, and the two issues that were quite widely discussed was the risk of hypertension and hyperlipidemia, and therefore the risk of increased major adverse cardiovascular events, or otherwise known as MACE. To cut a very long story short, it would appear that there is a higher risk of hypertension with the use of dolutegravir, which is now more increasingly being the main antiretroviral therapy being used as compared to efavirenz. Be interested to hear what is the combination treatment favored here in Pakistan. And this is results from two large studies called ADVANCE and NAMSL, showing higher risk with DTG versus efavirenz. And there have also been a number of observational studies which showed high risk for hypertension in those receiving dolutegravir versus other antiretrovirals. So what this means is that we all, in looking after our patients, really need to look beyond just managing their HIV, but also pay attention to primary care issues such as hypertension and hyperlipidemia to ensure that our patients, although they are doing well on HIV, that they're not going to have future complications of major cardiac events. I haven't included the slides here, but there are also slides looking at the epidemiology of MACE, which shows that low middle income countries have higher incidence of major cardiac patients living in low income countries have higher incidence of major cardiac events, patients living with HIV. And it is because it's a combination of risk factors, including hypertension, diabetes, and other lifestyle risk factors that we also need to address. Related to that is the presentation of a very large and I think also an important clinical trial, the REPRIEVE trial, which looked at prevention of, again, MACE in people living with HIV. And this is specifically looking at prevention of hyperlipidemia using a drug called pitavastatin. It was a very large study, and the hypothesis is the incidence of major cardiovascular events is not just as a result of high cholesterol, but also a number of other risk factors putting people living with HIV at a higher risk of these cardiovascular events, particularly chronic anti-inflammation. And the hypothesis is that statins not just reduces LDL cholesterol, but also in terms of addressing the chronic inflammation, and also provides immunomodulation to reduce the risk of cardiovascular events. So this was a very large trial involving more than 7,700 patients that were that were in two arms, either pitavastatin or placebo. And the primary endpoints were cardiovascular death, myocardial infarct, unstable angina, TIA and strokes, and arterial revascularization and peripheral arterial disease. And basically, the findings were really quite significant, which included a 35% reduction in major cardiovascular events, including 21% reduction in the incidence of major cardiovascular event or death. The LDL was lowered by a third. However, there was a higher incidence of diabetes and muscle-related adverse events, but this actually, when looked at in more detail, was no higher than what is expected at baseline for certain populations. This reduction of cardiovascular events was similar for people with high or low cholesterol at baseline, indicating that the benefits associated with statin went beyond the lowering of LDL cholesterol. Okay, so this trial was using this drug called pitavastatin, but as you know, there are concerns using statins with antiretroviral therapies because of the drug-drug interaction. So in using a cholesterol-lowering agent, you just need to be aware of this drug-drug interaction. And the recommended statins in HIV include pravastatin, atorvastatin, and hopefully at some point this newer statin, pitavastatin, will be available. Okay, that's just a conclusion that primary prevention for raised cholesterol should be considered in patients living with HIV to reduce the incidence of MACE. So the next big thing that was highlighted in Brisbane is of course U equals U, or undetectable equals untransmissible, and this was something that was championed by many people, but in Brisbane this included the World Health Organization, who launched their publication in the Lancet, where they did a systematic review of 8 studies of sexual transmission of HIV in 0 different couples, more than 7,762, or involving more than 7,000 0 different couples. And what the study showed was that in people living with HIV who had suppressed but detected viral load, meaning less than 1,000, the risk was almost 0. In this 7,000, in this systematic review, there were only 2 people who seroconverted, and certainly in those who were who had undetectable levels, that is less than 50 or less than 20 if you have very sensitive viral load monitoring, the risk was 0. So this is certainly something that we all need to be aware of. It's important in terms of the ongoing stigma and discrimination of people living with HIV, and certainly it's a great motivator, I think, to ensure from both the individual level as a public health level to expand antiretroviral treatment to people living with HIV. And finally, in the last few slides, you know, as someone coming from low upper middle income country, and I'm very much aware of the difficulties of expanding treatment, not just in terms of the first 95 testing and initiating treatment, as well as maintaining undetectable viral levels, the 95 goals, but and there are certainly challenges every step of the way in terms of bringing those at risk to be tested, ensuring that they're initiated on treatment, and finally retaining them on treatment. But there were many examples of excellent programs presented at the conference of differentiated service deliveries that speak to ensuring that at each point of the cascade that we achieve what we've set out to achieve, which is at high levels of testing, initiation of treatment, and adherence. And this is one example of a very large cluster randomized trial in Uganda to see how can one improve retention and to treatment, and looking at very hard outcomes like viral suppression, and what they found was really utilizing peers to reach out to individuals living with HIV was very effective in ensuring retention to treatment and linkage to care. So it was quite an intensive kind of intervention, which involved sessions at diagnoses, visits at home at 2 weeks and 6 weeks, and support with navigating these individuals to sessions at clinic and during first visit. But certainly this added intervention paid off, as you can see in that there's high retention in, first of all, in the clinical trial, but also, as you can see here, in linkage and ART initiation, retention on treatment, compared to control, where it was business as usual. And certainly in terms of the hard outcome of achieving undetectable viral load, you can see the significant difference between those who received the intervention versus those who were business as usual. So in summary, this ECUBO trial concluded that post-test support to navigate linkage challenges improved not only linkage to care, ART uptake and retention, but saw viral load suppression compared to standard of care. Okay, I'm not going to go through the last, I think there are about 40 slides or so that summarizes the presentations either as posters or as abstracts at IAS 2023, but it really is, and you can find this on the IAS website, of the many different examples of innovations across the world in differentiated service delivery for testing, for PrEP, for HIV treatment, for those who have been lost to follow-up and are being re-engaged. Suffice to say that very good examples include peer-led testing and initiation of treatment, as can be seen here from Thailand and the Philippines. Pharmacy-led practices, whether it's testing or initiation of treatment, and as well as PrEP, and of course community-based treatment, which is something that our colleagues in sub-Saharan Africa are particularly good at, with excellent results. So with that, thank you very much for, first of all, hosting this IAS Educational Fund, and secondly for being here this morning, and I look forward to great discussions over the next 2 days. Thank you.